Alrighty. Good morning, everyone. I hope you had a restful new year. I am proud to see everyone back here and happy to see familiar faces as well as some new ones. I called this meeting of the Medical Psilocybin Advisory Board to order. And then do we have a draft agenda? I know we were just doing kind of an overview from the department and then checking in on committees, but do we have a finalized one?
Yes, we do. Ian, I am pulling it up now. It's just taking it a moment. You
Oh,
should
perfect.
all start to see it. Can people see the PowerPoint now?
Yes.
Okay, great. And here is the agenda. And I will be putting that in the chat as well.
Perfect. All right. And then if we have a board member to move to adopt the agenda,
I move to adopt the agenda.
any seconds?
I second that.
Perfect. Um, all right, we can go ahead and adopt the agenda if there are no objections. So let's go ahead and just get this started with an update from the program.
Good morning, everybody. Thank you all for being here, especially our board members. We really appreciate it. It has been a very busy couple of weeks. The committees have been meeting, and it has been really great to hear it. I know there'll be more information and updates from the committees, but it's just been really great, and just hearing all of the comments and the commentary has been really good. I do want to say we have had one issue with regard to some of the meeting minutes, and some of you may have heard this as before the meeting actually had officially started, but what we're having is we're having a few people who are sending us lots and lots of documents and no context with the documents. And some of them are things, for example, just rules and regulations from Colorado or from Oregon without context in them. And that means while we have to put items like that, then do go as part of the record, those are already documents and items that are available elsewhere. And so what we are going to be asking and doing is stating that if you're referencing a document that lives somewhere else, what we just need is we just need the hyperlink to it. Because otherwise our concern is people are going to see in these records and the documents hundreds of pages, and instead of actually looking and seeing the analysis, recommendations, thoughts, people are going to simply just say, I'm not going to bother reading this because there are hundreds of pages. And so if you're referencing a particular aspect of, for example, an area of the regulations from Colorado, actually just cite that particular section of the regulations, that particular point, and include the hyperlink so people can go to it themselves and put in what you're trying to talk about and what your point is, rather than just simply sending in pages and pages of regulations. And other than that, we continue to move forward in supporting the board with regard to the meetings, and we're continuing to get things posted. The other update with regard to that is please do remember whenever, and this is for everybody in the public, and glad to see so many people are here right now, that as we do post items, because they do have to be reviewed for things, for example, in one committee meeting, there was a cuss word that was said. So our team that actually reviews and goes through had to mute that particular and bleep that particular section. So those sort of things have to be reviewed before we can put them out there, because once we do, these are available to the public, including individuals who are underage. So it is also our reminder of please watch what's being said. And just some of the other things that have occurred in the past is some people have given us feedback that they'd like to see everyone. And there are a couple of reasons why we don't have cameras on for the participants in it outside of the board members and some of the program staff. And the reason for that is actually twofold. One is because because we have so many people joining in on the meetings, some people were experiencing problems due to the load for their internet and their internet connection, and especially in areas where their internet was not so great, they would keep dropping out and having to join back on in. So we do that to try to help that stability with regard to that. The other reason for it is because there occasionally have been things that were inappropriate in the backgrounds. And so we have to minimize that and make sure that that doesn't happen during meetings. And while we are sure that it is unintentional, we do have to make sure, again, that the videos that are done, the recordings of these meetings, can be available to the public. And so we want to be able to ensure that. So those are the two reasons for that. And again, we would hope that in the future, we'd be able to at least have people visually in some of the meetings, at least for a brief bit. And we are looking into some of those potential solutions. But other than that, the program is just moving forward. We have been interviewing for the two other program positions. So as many people know right now, and he's on this call, our program manager for medical psilocybin is Jorge Gonzalez. And again, he is with us here. And we have two other positions that had been allocated to the program. One is a compliance officer, one is an associate environmental scientist, and we have been working on those interviews with those staff members. There was quite a lot of interest, and so quite a few interviews, and we will hopefully be moving forward with those positions here soon. So I'm hopeful that by the next meeting, or at worst case, the meeting after that, there will be some additional information regarding those positions. That will add a lot of capacity for the program. As many people know right now, technically the only individual who is actually dedicated to the program is the program manager, Jorge, which doesn't mean, by the way, I'm not dedicated to the program and that other staff members aren't helping. It just, his position is the only current full-time medical psilocybin position. So we will essentially triple our staff here within this, let's say, the next 3 weeks to a month. And that is great news all around, and we will be able to provide additional support and some other items with it. So thank you, everybody. And other than that, it's really right now we're in that administrative time of getting everything set up to be supportive. And so we really appreciate it. And again, forgive us as we make mistakes because we are only human. We will do our best to rectify when there are mistakes and as we get things moving forward. So thank you.
Thank you, Dominic, for that update from the program. Yeah, like you said, we're just kind of washing out all of the, little administrative tasks that are part of developing a program like this. And with the additional support, we should be able to fully flesh out this program. So what I wanted to go ahead and get into now was a summary or just kind of updates from the committees. I'll go ahead and go with propagation first and just see what are any updates. Have you guys, adopted governance, meeting for the first time? Just kind of a summary of where you guys are at. So I'll turn over to Chris.
Thank you, Ian. Yes, we had our first propagation meeting, and it was, I think it went very well. We had a lot of engagement within the meeting. We adopted our bylaws, and we just kind of began talking about where we're going with it. One question I do have for the rest of the board is, it didn't explicitly say this in the summary of the duties, but I didn't see it anywhere else either. So I'm kind of assuming that the propagation committee is going to take over, cultivation through distribution. And so we talked about that and all the work that needs to be done. And we have our next meeting set for next Wednesday, where we're going to start talking about cultivation. But if I'm wrong on our need to address distribution as well in that committee, please let me know. But I feel like it's the logical place for it to kind of sit.
Yeah. Yeah, that's actually perfect. So I had imagined the propagation committee taking over it would see everything the medicine sees before the patient. So if they transportation to the facility, everything but, preparation, administration, integration involving the mushrooms would be under that cultivation and manufacturing and that section. So I believe your interpretation is correct. I will go ahead and now go to equity, access, and cultural considerations with Desba.
Yeah, so we did have a couple of meetings. I did do a first morning meeting for those who are available during the day, but then I also had another meeting at night. I think I'm probably going to go back and forth between morning and evening meetings for some people, because I know it's not easy for everyone to get away during the day, and easier for some people to get away at night. But I don't know. I'd like some input on that from the public. But we had some meetings, two of them, and we did not do any governance agreements. This was more of a listening session to see an open, just to listen to what general public kind of had concerns of, where like the temperature of concerns. A lot of it was, of course, with the equity and access and cultural considerations, was cost for both facilitators, licensing, what that looks like, also for treatments. A lot of, so far, when I say a lot, I mean, there has just been a couple of people who have mentioned, rural access, telehealth, what that looks like. And, but then of course, what that looks like when it comes to how equity, access, and cultural considerations looks like in the framework of all the other committees. That's one of the things that I definitely want to kind of focus on, is where does that intersect all the other committees, all the other areas that we need to have concern, because I see that, and also in some of the other presentations, is the affordability and the access. Access is also education. What does the education and outreach look like? There was a lot of outside input, which is not a problem. We have people from Oregon talking about them having their own programs and business and how they were affected in Oregon. I haven't really heard anything necessarily from Colorado. I've heard some concerns from Arizona. Again, all of this input is interesting to hear, especially since Oregon has already established their program. But we definitely, of course, need to have all of that consideration for New Mexico. Let's see. There's also some other things in the meeting notes. One point, for the sake of the public and then also for the board, is that we did discuss how the regulations are going to possibly affect tribal governance when it comes to the 24 tribes. So we do have a tribal liaison within the Department of Health who Dominic can speak a little bit more to that if he would like to. But my understanding is that we're going to wait, because there is a legislative session that will be happening next week. And so we're going to wait until we can get some more meetings set up and utilizing that liaison to then reach out to the tribes and have more formalized meetings and listening sessions for what the tribes particularly need. And again, also for the sake of the public, because New Mexico represents 24 federally recognized tribes, which include the Apache tribes, Navajo Nation, and the Pueblos. They just recently changed their governance, which they do every year. So we're waiting for that kind of catch-up period to establish what the governors, who they are, what's going on, their change in governance and leadership right now. So it's not as if it's not on the radar, but we're going to wait for a little bit to get that going specifically. And yeah, I would say that that's pretty much all for right now. And then for the next meeting that I do believe is the 21st of next week, before we have some more meetings, and that one will be establishing more agreements. That one will be more formalized. So that's all for right now.
Thank you so much. I appreciate the update. The Training and Education Committee has not met yet, but they will be meeting on the 23rd. How about an update from the End of Life Care Committee with Larry Lehman?
Oh, and just real quick, just to clarify, it's the 20th for the next equity and access meeting.
Okay. Yeah, the 20th, and then the Training and Education is on the 23rd, no?
Yes, it is.
Yes.
Okay, perfect. Yeah, so that one's going to be on the 23rd, so please be sure to check in that one. Very important stuff with how we're going to pick who can, you know, prescribe and who can recommend these treatments. So it is very important. I will go ahead and turn over again to Larry Lehman.
Are you able to see my screen share?
Yes.
Great. Okay. For some reason, it's saying my mic is disabled, but clearly it's not. So good. Anyway, good morning, everybody. Good to be meeting with people again. We had one meeting at the end of life committee. We all approved bylaws. We focused some on scopes and responsibilities, and I was just going to go over that a few slides to kind of share what we focused on and what we saw as the direction that we wanted to head in. We also had a good amount of time for public comment and such. And we had to get, I think we had close to 50 people on the meeting. It was a big crowd, so I thought it went well. So we started with 6 and added a 7th scope and responsibility, and gave it some input for each of us. One of them is establishing the definition and the scope for end of life criteria. Um, the committee and the public input as well, agreed with the idea of trying to have relatively expansive time frames, including from the time of diagnosis of serious terminal or life-limiting conditions, and with the recognition that end of life is approaching due to natural aging. So the general idea of trying to have a relatively expansive, and that this is not limited to immediate hospice care. We focused on the idea of therapeutic, team development, and part of that, is the idea that this needs to extend beyond, strictly medical providers and licensed therapists to include, nurses, palliative care, more roles such as psychedelic end-of-life doulas and chaplains, and discuss the idea of developing an entry-level facilitator role for inclusion. And this would obviously overlap with other committees, but that was one area that we thought was important to maintain access and equity. We think that end of life may be unique among the 4 indications of being able to include family and caregivers, because it's not a specific diagnosis, but it's an end of life process. And so we're interested in having life partners, family member, one other person participate in the psilocybin assisted therapy to help with the end of life care. The site came up, and with end of life and different people's wellness states, the idea of having home-based end of life care, it was felt to be particularly important. The idea of coordinating with hospice organizations, home health agencies, was also discussed. The education and workforce development was discussed. The main discussion items are that the feeling that everyone who's involved in offering psilocybin for end of life care, would really benefit from some very specific education. And also we discussed some that there are actually fuller programs that are out there where people can relate that if this is going to become their primary focus. End of life care plans, we discussed, the preparation, integration, psilocybin dose, number of sessions. Some of those will be specific to end of life care, as well as involvement of family and caregivers. And, similarly to, what Desbo was mentioning, the idea that this will overlap with other groups. So we wanted to focus some on the actual specifics that are important for end of life care. And then our part of our role would be to a periodic review of scientific literature. So that was our main focus as far as the content. We decided that we're going to meet every 2 weeks, and we have a meeting set up for next week. One thing we decided in our group is that we're going to try to probably put in about a 15-minute sort of in-service educational session, at least for the first few months, to bring everybody up to up to speed on some of the issues. An example was mentioning that there are specific issues as far as dosage and stuff with end-of-life care from a Barnaco point of view, understanding the role of psychedelic death doula. So we're going to do some in-servicing education for our committee as well. That about wraps it up. So we're looking forward to our next meeting next week.
Perfect. Well, thank you for all of that. That sounds like you guys are doing some great work in that committee. I completely agree with the openness of having end-of-life care, especially because palliative care can include things like hospice, but it can also be areas where we may still be able to cure it, but we just want to make them more comfortable and take care of the people that are, suffering. So I really appreciate all of the work that you are doing. Next is research and continuous improvement with Dan Jennings.
I appreciate it, Ian. Thank you very much. We had our meeting last Friday at 9 o'clock. We'll probably be on a 2-week cadence as well at the same time. So we'll plan on meeting next Friday at 9 o'clock as well. We had about 20 individuals that came to the meeting, a lot of great discussion. We focused on a couple of different things. First was we don't have bylaws. We just have some norms that we center around so that we can just kind of get our work done at this moment. Our responsibilities in that group that we wanted to kind of take on first are core data elements. If we're looking to track information that's going in and out of the medical psilocybin program, we wanted to make sure there were some good data elements and then also some research and best practice or references materials. So we worked on a set of both. We got through presenting both of those two sets to the group, and our intentionality is for our next meeting where we'll be able to kind of come to a consensus about the lists of the data elements and the research and best practices that were presented. We'll continue to have that same flow. So as individuals will present research, one of our norms we focused on was it should be based upon primary research, not secondary or tertiary, and also to be very aware of biases that would show up in that research. So what we're looking to do is if somebody has some material to present that this should be something we should look at as an advisory board, that this group could look at that and then have good discussion around that research area, talk about it, and then come to a voted consensus to make recommendations that would be something we could look at. Despa made a very good comment in our meeting that this RACI committee is almost like a two-way street. So meaning that there's a lot of research that all of y'all inside of your committees may rely on and also reference. We would like to have that information. So if you, from a committee chair, have research that you're using, if you would send it on our way, we could include it into that list. So we would just want to make a really good continuum bibliography of the research we focus on. Another thing that came out from the discussion of that group was the idea that there should be adaptive regulations. So this committee may be one that as this program gets implemented and off the ground, that could be kind of an entry point for here's some new research that committees could look at to make changes and adaptive in those regulations that they came up with. We also, in the data elements, had some very good discussion around different things. One of the things that came up, since this committee may have a footprint in outcome monitoring and adverse event reporting standards, the discussion came around that maybe instead of calling it adverse events, it's challenging events. Words do matter. So it might be something that we look at and we'll take a vote on in that sense as well. We'll also be doing some ad hoc work assignments or homework. And so our next meeting, we're going to start to center around what are the next steps for this group to work on so that we can be helpful to all of y'all on committees and to the program as well, and kind of outline what we can do to help with. Ian, I did want to ask you a question though. One of the things we do have in our committee responsibilities is the risk screening and medication interaction guidance. I kind of have a feeling that probably y'all in the dosing committee are probably going to be focusing on that as well. So give me some direction if that's something we put on the back burner, if that's something that dosing will take care, or just tell me how we should, so that we work together on that.
Yeah, so I know that the the Patient Qualification and Safety Committee is going to be creating a list of patient exclusion criteria, which will include medication interactions. So I guess, not I guess, I put that into your language because I wanted the research and continuous improvement to look at it after the fact and say, okay, well, we've had a lot that have taken this medication and now they're having adverse reactions or challenging reactions. And so just so that there's a way to implement and fully flesh out the program, because when one of the things that I imagine is that the continuous improve con, research and continuous improvement, Jesus, part of it would be an ongoing committee. And so even after we have everything, set up, fully functional, if people still want to present evidence and still have things to challenge us on, I wanted to give them an open door to say, hey, you can 100% work for this program. If you disagree with something we came up with, here's the avenue to change it. And that's kind of why I gave you guys that authority. It wasn't necessarily to say this is your first priority. It was just like if something happens and people are very upset, which I don't imagine happening, but that way there is that path. There is a path forward for communication and collaboration.
Perfect. Thanks for clarifying that. I wanted to make sure. So that's kind of where I looked at this committee will continue to work on some of that adaptive things later on. So appreciate the clarification.
All right, and then with that, it leaves just two committees left, the patient qualification and dosage administration and clinical practice. So for patient qualification and safety, we had our beginning meeting, we adopted bylaws, and we also adopted definitions for the initial qualifying conditions. So the legislature had passed that 4 qualifying conditions would exist: substance use disorder, PTSD, treatment-resistant depression, and end-of-life care. So we just put them to ICD-10 codes in order to make it, more standardized to work across the committees. Because if I'm treating a specific ICD-10 code, then I can set the dosage for that code. I can then set patient safety standards for that code and work to make sure it is fleshed out completely, considering their diagnosis and what is kind of happening with them, especially when we're given, terms that are not medical terms by the legislature. So substance use disorder is not a medical term. We would use the specific use disorder. So amphetamine use disorder, cannabis use disorder, whatever it happens to be, that's what we would use. So I just provided ICD-10 codes, and that's what the Patient Qualification and Safety Committee has been up to. Right now, they're pending a meeting on February 20th to flesh out those exclusion criteria, make sure that we have a good baseline for where we're starting this program, and making sure we're starting on the foot of patient safety first. The Dosage Administration Clinical Practice Committee has met. They have adopted bylaws, and they are just working to interpret those codes from the Patient Qualification Committee and set up a dosage regime for each diagnosis. Because as we know in medicine, oftentimes the dose to treat one disorder is not the dose to treat another disorder. And that is my update from the committees. So we can now go ahead and move to other business. Is there any other discussion that we have from our board members? Seeing no discussion, I guess I'll kind of open the floor to a couple things that I have been thinking about. So one of the big components that we have to have in this program is propagation and cultivation of our mushrooms. So I personally would like the board to set a goal of having them completed by May. That would give us time to allow the secretary to either approve or deny our recommendations. It then gives us time for the department to fully promulgate those rules and allow us to have the producers begin, because we are going to need the producers ready months before we have our first patients. So I will just open the discussion for that if anyone has any questions, comments, concerns.
Sorry, hold on. Sorry. When you say May, Can I just get a clarification? You said again, to adopt something by May so that we can start having the patients.
No, the cultivation by May.
The
So
cultivation.
just the
Right.
growing the mushrooms. I don't think we're gonna have the whole program ready by May, but
Mhm.
I just want to have us to be able to start licensing those growers. That way in 2027, when we have our first patients, the supply already exists. That way we're not trying to run at the last minute to grow these mushrooms. Instead, we can say, okay, we have it licensed, we have it tested now in the real world, and we can say, okay, this has been adopted, this is working out. Now we feel safe to take our first patients.
I would really appreciate this. Might have to go into public comment territory, but what I'm understanding, at least from my perspective, is it maybe need to be reverse engineered in terms of timeline by what we have established already to do the testing. What facilities that and framework and structure do we have already in place for those things, and what are those standards prior to being able to figure out what that looks like? And that's just with my limited thinking as far as like what needs to happen first with the timelines. Because I think that if we're doing this all in-house, and when I say in-house, I mean within New Mexico, I'm actually don't know where the facilities are for these types of things and who has it. And I know that that might be also in equity access considerations, like who actually has some of this equipment can be costly, especially when it comes to like large batches of this. I know that individual testing might be possible, but what are those things that we're looking for? And then also how long it takes to get those results back. And so my first thought is just what is that? You know, what is the structure that's in place before we can do the testing, and what are we looking at when it comes to the testing? And then from there we can figure out what that looks like. But that's just my first thought. Sorry.
Yeah, no worries. Actually, while I was in the propagation committee, Rio Grande Analytics had already basically explained it was the same technology that they're using for cannabis. So our infrastructure is already pretty existent, but I will go ahead and turn to Dominic. He had a comment.
Yeah, thank you, Ian. And Disba, I completely understand what you're talking about. What Ian was mentioning in the beginning is we do have to prioritize the cultivation and the testing sort of together in parallel so that we can ensure that there is product for those first patients. And when we look at it from a standpoint of seeing the first patients in December of 2026, the cultivators are going to need several months for that. The points you raise about how long will it take to get the products then tested, all of that work really means we need to be able to license producers or cultivators really by this summer. And then as well, also the potential labs. Now, again, as Ian has said earlier, and I've said in pretty much most of the meetings, it's not going to have everybody who potentially is going to be engaging in the program as cultivators, lab testing, and all of that by next December. But once we open those applications and can start taking them, we do need to have at least a few to be able to produce products and to be able to test them. And so that's a part of the process. But it's not like we're going to open the applications and then just shut them closed. It's going to be an ongoing process. So in order for us to be able to have licensing by this summer, it means those rules with regard to cultivation and testing, we need those sooner, by this spring, essentially, so that we can have that process. And it doesn't mean that the other parts of the process aren't happening. The ideas of the patient aspects, the dosage aspects, all of that is still continuing to move forward, and we'll have those by about early fall to mid-fall to have all of that in place. But we can't see any patients at all if we don't already have a product able for them or timed out for people to be able to utilize that medication in December when those patients are seen. I hope that helps clarify it a little bit. So it doesn't mean all the other work stops and we wait until this part is done. They're all happening in parallel. It just means we're going to prioritize the regulations for cultivation and testing first, if that helps. I hope it helps.
And then Chris, you had a comment? You're muted, Chris.
I was going to say that was just kind of going to be in line with what I was thinking. I'm going to attempt to work through the cultivation piece first and then get the testing. If I need to, we can kind of flip-flop meetings to kind of do those concurrently. But I would like that to kind of be a more phased approach if I can, and get the cultivation piece out first in the next couple months, and then the testing piece out following that, and then put off all of the distribution, transportation, production type stuff until afterwards. As I feel like we're going to end up taking a lot of that from marijuana laws that currently exist. So that's kind of my thought process on it, and we're going to dive into cultivation on the next meeting. So
Perfect, thank you. And Larry?
Yeah, I support the idea of, like, of front loading that. I also agree though, Desma, somewhere we're just gonna have to see what happens as we're doing this. I mean, see what obstacles that we encounter, but clearly the propagation seems first. I do want to throw though quickly into the mix that training has to get and started pretty quickly too. I mean, at least in other states, the training programs are, 5 to 6 months. They have to be either created, or we have to, decide about reciprocity with other states and how we're doing that part of it. And so I guess I'm jumping on the timetable bandwagon and suggesting that training has to be done soon, so that there's somebody who's skilled and can be approved to be offering the therapy.
Perfect, thank you. And Brenda?
Yeah, I agree. Since I'm the last person to have these meetings, this is all coming in like a full scope here with everybody playing their parts here. But yes, I agree with Larry, the having people that are already gone through programs here, what that's going to look like. And that's what I'm going to be opening up in our meetings. It's already have all of that uploaded for our meeting. So this is going to be one of those things where it's going to be pretty much a template of working with what people have already learned in their trainings. And will we be letting in people that are already trained into this program and hit the ground running according to all of the rules and regulations and the training. So I was thinking, of having at least as many meetings as possible, because this is a lot for many people that are already here that want to start practicing. A question, just talking with friends and all of that, will we need to have licensing for all the people that are already certified in in their education, and what that's going to look like. So there's a lot to be discussed in the meeting for training and education.
Thank you, I really appreciate that. And yeah, I don't know if you want my opinion, but I think it would be perfectly okay to offer reciprocity as long as we gave a New Mexico specific course, just so that we make sure that they're informed of our laws. But I think that that's great work, and I appreciate all that you have been doing. Desba has a comment.
Yes. So kind of, at least to summarize, like what we're talking about right now, a couple of things. So sometimes, just for the sake, I ask questions maybe that I may have like I'm trying to learn myself and come up to speed, but then also what I feel like is the temperature that might be potential other questions that maybe everyone else might have. And it's also basically just for clarification of what's going on. But it's good that we're able to clarify those points. So yeah, totally. What I'm understanding right now, at least, and just for the sake of clearing it up, is that we're trying to figure out at least the already established people who are on the side of propagation and also on the side of training, already doing the work, have done the work in their own capacity, but who are here in New Mexico specifically. Now, even if they have training from elsewhere, where we're going to look at the reciprocity for that, but then also cultivators who may already be establishing their work, have already done their work, and are already using the testing. So those people in those capacities, and let's just say professional people in those capacities, relying, not necessarily relying, but maybe utilizing their expertise in those fields to help get this first segment going by the end of the year. And then from there, we're continuing to create more workflow for when it becomes more open to the broader range of 10 cultivators, 20 cultivators, 10 licensed professionals in their various capacities, whether they're indigenous leaders, nurses, therapists, and any of those things is what I'm hearing. The one thing I'm thinking that would probably be useful as far as who loves to do these types of things is a visual timetable that can be manipulated to kind of at least plop down what we're looking at, and then we can figure out from there, we can move it around. And similar to that, back to Dan's, how research and is going to be utilized in the various different ways, whether it's what dosages work, what training works, because this is going to be a never ending, I can't think of the word, but it's just going to be never ending in terms of getting it right and how we're working through it. I believe Dominic gave the example of cannabis, 20 years ago it started, and now we're still kind of working through the kinks and trying to figure out what works for New Mexico and its constituents. So that was just a kind of summarization and also an added comment.
Yeah, and I really appreciate your input. I definitely do agree with the reciprocity. One of the things that I know from my experience in living in Texas is that their medical cannabis program had two dispensaries. And so what that meant for prices was crazy. What you could buy for $15 here was $70 over there. And so I think that if we offer reciprocity for things that are not, going to change between states, like cultivation is not going to change much. If you can grow a mushroom in Oregon, you can probably grow it in New Mexico. It'll be a little more difficult. Our weather is a little less friendly, but we can definitely work with that. And so um anything we can do to expand and on the competition in the medical psilocybin market is really important to me because I want the best quality medicine for the best price for our patients. Dominic had a question or comment?
Yeah, I just wanted to say, so part of what some of this conversation is about creating that priority so that we can assist from a department standpoint in helping to create that visual that you're asking for at DESPA. And so if this group is in agreement with the cultivation and then the testing, we can start working on that, and then we can add in those other pieces as the various committees say, okay, what does it look like for our timeline and when to get these proposed regulations and sort of moving forward with that. And so essentially helping to create that project plan. But like right now, what you've got at the moment is the committees are gathering information, hearing from the public. And so now is the point to start creating that plan. And I will say that as a department, we do have some ideas and things like that, but we also want to make sure that this is being done transparently and is actually having that input from all of you, and not just the board members, but the public as well. And so we don't want to unduly influence that. And so that's a part of it. And so now, as the committees continue to meet forward and start to think about those timelines and not just hearing some of that public information, we can start creating that project plan and those visuals for you.
Perfect. Thank you, Dominic and Chris. Still muted, Chris.
I'll get there eventually. Sorry, guys. I have two thoughts. The first is that I think the training piece really should be probably co-prioritized at the beginning. I feel like we really need to get our people up to speed on that as quickly as possible, because it's going to take more time than we think. I'm in a training program in Colorado, so I can help out with Dr. Lehman's study, and it takes a while. So, and then my second thought is on reciprocity with the cultivators. I think we have plenty of cultivators here in New Mexico that are up and ready to go right now, and I don't think that's going to be a problem. They may have to make some adjustments, but I also feel like some of them have been aware that this might be coming and can make this happen. So that's all I have.
All right. Well, thank you so much for that. And I do believe this program should be New Mexico first. I just think that in terms of reciprocity, it can allow expertise from different areas to flow in. And especially because this is the first time our state is doing something like this, I do want people who have a lot of experience. And while I do know that there are plenty of homegrown, maybe they don't want to get interested in that. I do think we should have a preference for our New Mexican growers, but I don't think it should be exclusive to New Mexican growers. I think there's expertise in many parts of this country, not just the state of New Mexico, although I do think we are the best. All right. So if you guys wanted to set some, preliminary dates, we could do that. Say, we could do March 1st, have all of the lab testing information ready by April 15th. We would have the lab testing and the growing requirements pushed to the board. That way the board could, as a whole, review it, see what it is, how it's doing, and then in our meeting in May we could get along with that. How about I have a question from Dominic.
Ian, I actually would recommend that we do that by February. And the reason I say that is the process with regard to regulations is that we actually have to have public hearings outside of this board. So they're just regulatory public hearings. I shouldn't say just, they are very important, but they are regulatory public hearings, and we have to provide 30 days notice. And so I would say that we present by mid-February as far as a draft with regard to cultivation and testing. And then I would say by the beginning of March, and this is what, addresses some of the concerns that people have. Because again, while we say prioritize, we're only talking small differences in timeframes. So I would say some of those others as far as training and certification in early March. And what that does, and then the others can sort of follow afterwards a little bit. What that really does is that allows for the 30 days notice for public hearings to occur, those public hearings for the rules to occur, and then adoption of them after that. And so I just want to suggest that as far as timeline, just looking at those other pieces that also need to be there, because it's not just the board doing that recommendation and then them getting promulgated. The rules actually have to go through a separate rulemaking process.
Yes. And then Chris.
I'm sorry, did you did you say March for testing and cultivation?
So I
Or
had said
May?
March. Dominic had corrected me to say February to allow for the full promulgation procedure. It involves a lot of public discourse. It involves a lot of posting in official registers and making sure that that information is available to the public and can be debated, and that all the parties that are going to be impacted can speak on it. And that takes a long time. If you want to know like an example of this in the real world, look at the federal reclassification of marijuana. It has been pending for 2 years because we've been waiting on public hearings and judges changing and things like that. So it is a long and strenuous process. So he had actually recommended mid-March, or I mean mid-February for cultivation and testing, and then mid-March for training and certification.
That's a pretty quick timeline.
Yeah,
Yeah, it is a little bit quick, but I do believe that with this, it's an effort to push our resources toward that cultivation and testing. We can, if you need assistance, chairing some committee meetings or, whatever you need to help you support you and get you through that, we can do it. But in order to meet that administrative, deadline of 2027, we have to have these things ready to go through the full public hearing process and ready to go through all of those rulemaking procedures in order to allow this to actually become official. And then Larry?
Yeah, this is really, Dom, this is a question for you. One thing that's come up in discussions came up in the end of life is if we're going to have like a facilitator, similar to what they have in Colorado and Oregon, which does somewhat of a similar training. Does that actually have to go back to the legislator to create that, or is that something that can be done at the level of DOH and the secretary?
so can you explain a little bit more exactly what you mean, Larry?
Sure. So, the what they do in Colorado, really everybody needs to go through some facilitator training to be approved. And they actually have like a licensed facilitator position there. If we were going to do something like that in New Mexico, just came up with the psychedelic death doula idea, and this person would be a direct entry. They're not a therapist or a physician. Do we need to actually have a bill to create such a position, or can we do that internally?
Okay, so gotcha. I was just trying to figure out as far as certification aspects of it. No, it does not need to go back to the legislature. That is something that, as the regulations get promulgated, was assigned to, technically it's to the department, because we're the ones the department will be who actually promulgates the rules. And so with regard to that, it does not need to go back to the legislature. It stays and remains with the department and, of course, with this advisory board for making those recommendations. So, for example, is the question that's come up with reciprocity, if, and this would fall under the training committee. So with Brenda, if that training committee made the recommendations and this board accepted them for reciprocity, and here are the conditions for reciprocity, which I would say would be, just to sort of throw out there, and of course, other details to be determined, but that someone already be certified in either a training program that has already been deemed an accepted program in either Oregon or Colorado, that they prove that, and then, as Ian said, have a module, which we're looking from a department standpoint on creating, that would be specific for New Mexico, about the New Mexico statutes, regulations, and of course the protocols as those come forward, that be then available, and they have to complete that as well. And then in that kind of a situation, the reciprocity could work. So we already have quite a few people. I mean, many people have reached out saying, I've been certified and trained in Oregon, I'm a certified facilitator, I'm in this. And so that would allow for the people who already are to be able to do this a little bit earlier. And as well as having that reciprocity, to be able to have what are the requirements for training programs moving forward and to have that available. And I know there's been a lot of people who have asked and said, people have to be trained in state. We want only people who are New Mexicans who are doing this or who are living in New Mexico. And those are some of the details that the training committee can really be looking at, is what would work from an equity standpoint, what would work in order to make this fair. Some people have suggested, for example, doing, while we initially do this with regard to reciprocity for the programs from other states, that there be essentially like a sunset clause, so that if you haven't done that by a certain date, then at that point you have to go through a program that has been established in New Mexico. And so that sort of thing. So it sort of helps in both areas, where first you have people who already have been trained, and then it focuses on people who are already here rather than continuing to have people just essentially coming in from elsewhere. And so those are some things that have come up, and that I know Brenda's smiling and laughing, because I know we've talked a little bit about this and some of the other folks are too. And thank you all as far as the applause. That's really great to hear that there's a lot of support on that. But those are some of the ideas that have been coming out. We've actually been talking about them for months. I can't even remember. The first time I think we talked about this was during legislative session last year, so probably a year. And it was one of the reasons why we actually do not have that as a requirement, to have to go back to the legislature to be able to make those requirements as far as the certification of practitioners. So I know that was a really long answer, but I see all these messages in the chat, and I was trying to kind of cover answering a lot of those, and I hope I was able to do that. And so thank you. And Larry, I hope that answered the question in a long roundabout way.
Dom, super helpful, very clear. Appreciate it.
Thank you.
Perfect. And then I have Brenda raising her hand.
Dear Dominic. This has been, this has been one of the focus for my first meeting is the reciprocity with all of this, and trying to do this as quickly, efficiently, and to the point with the training. And like myself, I was trained in MAPS and spent thousands and thousands of dollars, just like many people here in our chat that have been trained. And so thank you so much for explaining that in a nutshell, because we're folks, we're going to be getting into it. And now the deadline is March. I hope the end of March. So that means probably I'm going to try to have as many meetings as possible between now and then, because that's a very short timeline, but we have a template to go by. The majority of people here have been trained and meet the requirements for New Mexico, and like Ian said, have like just classes just for New Mexico that are not going to take up a whole lot of time, like months and months of time. Maybe just a class that covers an awful lot of what we've been talking about here, in order to get people trained and ready to go. And that includes everything, from history all the way up to dosing to what we're doing right now. And this is going to flex and change a little bit here and there, but I think we can do this.
I completely agree, and thank you so much for your comments. I do also want to include, because I do know of quite a few stories like this where New Mexicans went to Colorado, got licensed, and are practicing there because that was available to them. They wanted to work in the psychedelic space, and that was already available. And so they got their licensure in Colorado. I think it would be fantastic if this board could work to bring those New Mexicans back home and allow them to work in our psychedelic program here. I do know a lot of people that this medicine is incredibly important to them, and it's incredibly important to me too, but where they wanted to devote their lives to this and they couldn't do that in this state at the time. And so I don't think that just because they are licensed in another state means they are necessarily from that state. It just means that's where they happen to get a yes and we're willing to be trained. All right. And then, so if we wanted to go ahead and just adopt those original deadlines, we could say February 15th for um, cultivation and testing, and then March 15th for training and education. Does that sound good to everyone? All right.
Wait a second, February 15th, that's a month for all of the cultivation and testing. I think this is way too quick. Give me to the end of February.
Chris, those are drafts.
Okay.
Not like the final, like this needs to be the thing done. These are just, we need to be prepared. That way the board can have something to discuss and to fully move forward with those recommendations. I don't anticipate that these are going to be perfect when they come out of committee, any committee action, that it's going to be perfect, spot on. I think we have to do our job to independently verify all of the information we receive and not just go off of based on the authority of the person or on the ethos of that person. We must look at it independently. And so, while yes, it is a little bit quick to have those out, if we want to still keep the deadlines that we were trying to, it would be February would be the best time to have it done. That process for making a rule and administrative procedures take a long time. So I just want to point that out there. It's not that we are trying to say we need perfect, final done, ready for posting to everyone, but we need at least something that we can begin our discussions off of. And I also want to turn the mic to Desba. She had her hand raised.
Yeah, I just for the sake of clarity, can you restate the ask for those two committees in like a one sentence thing? What was the ask for the deadlines, the specific?
So for the propagation committee, the deadline was February 15th to have cultivation and testing standards.
A draft.
Yeah, a draft.
Okay.
And then education and training, I wanted by March 15th, them to have their draft of licensure and training requirements.
Ian, this is Larry. I'm sorry. I'm on my phone now because I got bumped off the computer. I think the March 15th for the training is probably too soon. There's much more intersection between all the different committees. I mean, we need to figure out what some of like the model that we're doing is here, and so I would be hesitant to set a date for that. I mean, we have major issues that we have to define, like in other words, what makes you eligible, who actually gives you a diagnosis, how does that relate into that? So I'd be careful. I mean, it honestly took Colorado 2 years. I'm totally in favor of trying to accelerate it, but like 2 months does not sound reasonable to me for the training part. And I'm the one who advocated accelerating the training part. I just think it needs a little more time than that.
Yeah, and I would be open to that. I do just want to stress, like, if I had all the time in the world, I would take all the time in the world. This is really about just trying to get this ready for those first patients. I would much rather set restrictive goals and then fail to meet our goals than to set really loose goals and not get accomplished our overarching, you know, priority for this year. So I'm not saying like it's all over if we don't get it done by March 15th, but I think sometimes in psychology, if you give someone a higher bar than they're able to reach, they jump higher. So that's kind of where I am at with this, but I will it looked like Dominic had a comment.
So here's what I'm kind of asking, and Desbos sort of hit on it a little bit earlier, and I had made the comment about project plan. Part of the reason why, from a department standpoint, we are asking for some of this is again, it's not a final version. It is a draft. We're not asking for approval by this. And so by doing this, what it means is, for example, and I'll just use the propagation, so the cultivation piece is with the cultivation piece by February, then what can happen is this board can look at it and say, you know what you have here is good, bad, needs improvement, and here are the areas that are missing, so that we're working with a little bit more specifics rather than the broad generalities. And I would say the same with the training, because you're right, Larry, it may be that it's still another 2-3 months after that, but that gives sort of a beginning basis to start saying, what are we missing? What have we looked at? What have we not looked at? And how do we do that? And so when we say having that presented for this board, it's not saying it's going to be a final version. It's really starting to say, here are some deadlines for some of these items, and here's what we really kind of need to move forward. Not final versions and all that. Although, I mean, if the committees are able to get final versions, that's fantastic, but that's not really what the anticipation is. It's to say, hey, by February, middle of February, we will have the beginnings in our draft for cultivation. What other things do we need? What is missing? What hasn't been considered? And what is good? Does that help? And so, for example, this first draft, it may very well then be at that meeting, the next step is, okay, we looked at it, we said you need to really work on these areas and parts, come back to the next meeting with that part completed, and sort of doing that as part of this project plan. But without having some, at least, deadline started, we could otherwise be spending months just saying, we're gathering information, and never really putting anything into action. And that's a part of why we're asking this from a department standpoint of, we need to start taking those actions. They're not going to be perfect, they're not going to be complete, but we need to start taking them. And I hope that helps.
John, this is Larry again. That sounds very reasonable. We're clarifying that we're going to see a proposal by mid-March about facilitation, but we realize it may take substantially longer, or at least some amount longer. I'm comfortable with that.
Perfect. And then Desba?
Yeah, that's essentially what I was just going to say, as far as, putting the sticky note on the whiteboard. This is where we're starting from with the draft proposals. And then that's where our committees are intersecting with respect to Larry's end of life care. What does that look like for the facilitator? And then also with respect to equity access is, does that include Indigenous, does that include rural areas? Does that include the equity of the training and the cost and effectiveness? And what does that look like when it comes to reciprocity? So that's where we start filling in the holes of each of these different, I can't think of the word, agendas, but I don't want to say committees, but, and dosage, et cetera. That's where all of these different committees are intersecting and adding in our 2 cents with respect to what the public needs into those places, which is where the public, we need the input from everyone else to say that this is what New Mexico residents need for this, for our care and our well-being.
Yeah, and I completely agree with that. I mean, I have always said, the people of New Mexico have so much more knowledge than the 7 of us combined. There's so much more wealth of wisdom in our communities. So, as much help as the public is willing to offer, I am always willing to accept. I did want to add on to what Dominic was saying. He had also mentioned in one of our committees that the department would be helping to kind of bridge the committees, helping to provide updates on what's happening in another. So what I wanted to clarify with this goal framing is that we're not saying suspend every other committee until this is done. We're saying, no, continue to work, continue to do your thing as we continue to patch holes in those committees. But we want to say, these we need to get, if these pass a committee, then they'll go to the board and we will take them up, and these are our priorities. But that doesn't mean suspend all work in all other committees. No, we still need to develop and have questions that need to be answered, and a question answered in one committee might be useful in another committee. So it really is about, collaboration, working together, and just making sure that, we have to put something out there. We could spend eternity saying, let's look at the data. Let's continue. No, we need more. We need more. We need more. You can continue to do that indefinitely. I don't think I've ever read a study where at the end it didn't say, but more research could be conducted. So I just wanted to say, you know, like Dominic said, we make mistakes. We are people. We are human. We are going to do human things. So I just want to let everyone know it's okay. We are working our best. We are doing our best. I believe if each of you are like me, I am working as hard as I can to serve the people of New Mexico who deserve access to this medication. So with that, I just wanted to say it's not a whole pause. We're just kind of focusing our intentions. All right, any more discussion? All right, then I move that we adopt those deadlines of February 15th and March 15th for those drafts from the, why am I blinking? Cultivation and testing and the education and training respectively.
Ian, if I may, I would suggest the February 15th or the closest advisory board meeting to that date.
Okay, so do you want to do, so how about we set it to be, yeah, I mean, that's a fair point. When do you guys want to have your next advisory board meeting? That's also of consideration in setting this.
I mean, nobody wants to hear like it's a day early, but the 13th is our closest Friday to it.
I would be okay with 13th.
And just as a note, the 13th is one day that the department would not be able to provide administrative support during the meeting. So I would just recommend a different date, either the 20th or the 6th. Or, I mean, it could be a different day, but
We
and
could
you
do the
can go with the
20th at
13th.
12, because I know the dosage administration, no, patient qualification and safety is meeting on the 20th. So if you all want to do the 20th at noon? Brenda, you had a question? No?
No.
When do you suggest?
Yeah, I will be in training there. Can we do it the 27th or the 13th? Well, the 13th we can't, but the 27th, is that possible?
So here's what we could do is, if
Okay.
you're all okay with this, is we could have the drafts available for review by the 13th and the meeting on the 27th. How does that sound?
Better.
I
Thank you.
would not be able to make the 27th. I could do the
Okay.
26th at like 3.
Yeah,
26 at 3, everyone?
Oh, Larry, you're speaking, but we can't hear you.
Yeah, I'm covering a hospital service. I can't do the 26th. I can do the 27th.
I mean, if you guys want, if you're willing to run the meeting, you guys can do the 20, what was it, the 27th? Right? That's what we were saying?
That's up to Dan, right?
That's the 27th at 9 o'clock.
Mhm.
Yeah, I can chair if you would like me to.
Perfect.
It's, I mean, up to you if you wanted to have like the, that involvement in it, but if you're not able to, then we can also catch up later too.
I'm gonna definitely try to move around my schedule and see if I can make it, but just in case I want you to, be prepared.
Yeah.
But yeah, the 27th at what time do we agree on?
9 o'clock, the same time slot.
Okay, 9 o'clock at 27th.
And if you all
So
adopt,
we will say the drafts are due by the 27th at 9.
Ian, I would say the draft's due on the 13th and
Oh,
then
drafts due on the 13th.
consideration on the 27th.
Okay. Drafts due on the 13th, consideration on the 27th. Is everyone good with that?
Sorry, what month are we talking about?
February.
Yeah, that's okay.
Disba?
Yeah, and so just so, again, for clarification, sorry, I shouldn't keep prefacing that, but if we have the drafts due on the 13th, then Dominic and Ian, that does allow for the review for the admin to post it, and then public can see it and do their homework. All of us can do our homework prior to the 27th.
Correct. And that's why I'm suggesting we post it by the 13th and have those drafts there, and then you all have them, and the public has them available to review prior to the meeting on the 27th. So that'll give about 2 weeks for people to review and look at them.
And
What
red
time
mark
on-
everything.
Yes.
What time on the 27th?
9 a.m.
Okay.
All right, now that we've set our cultivation goal, we can either set the training and education goal at the next meeting, or we can set it to be with the 27th. Which would you guys prefer? Because it is approaching the beginning of March, which is where Dominic had originally said the training and education might be due. So we should, if we want, we could push it to be with the 27th, or we could have a separate meeting for the training and education. Dominic?
I would recommend we do a similar process, and where we say we will post the draft by the end of business on the 27th for that one, and then it be considered at the next meeting. So again, people have time to review and look at it, and that it gives a little separation between the two drafts, so people aren't trying to do too much. With
Well, that
the
works.
caveat and understanding Larry's position as well, with the caveat that the training may not be fully complete. It is just a draft and starting point.
Yes. All right. Well, that all sounds good to me. Chris?
Can we set our follow-on board meeting too? Would it be helpful for people? I like to have a little bit more time to, or lead time on my schedule.
So the first Friday after the 15th would be the 20th of March. Did you guys want to do that?
If we're making recommendations on the 27th for education, wouldn't we want to review those sooner than the 20th?
So the 27th is going to be the cultivation and laboratory testing. Then in March, we're going to make the training and education committee due. So originally I had said March 15th, but the closest Friday to that is March 20th, or we could go before it and do March 13th. Chris?
I can't do the 13th, but it seems like if we're going to have the draft due on February 27th for the education, we should meet before the 20th of March.
Okay. Yeah. So the only other Friday in March would be the 6th. But outside of that, it would be the 20th or the 27th. The 27th, I want to remind you, the 27th of February is for that cultivation and testing. I'm looking at the 20th of March for training and education. So what I will go ahead and do is I will drop the meeting after the next one from this discussion, and I'll send out a scheduling thing, and we will be able to pick a date that works best for all of us in March. That way it's not like just throwing out random days and coming back. Does that sound good to everyone? Cool. All right, I will turn over to the department for public comment.
Okay, thank you. Adrian, I believe you will be handling our muting and unmuting. Just so that everybody knows, if you are interested in public comment and speaking, just raise your hand in Teams. And if you're on a computer, you can click on the hand icon that's near the top of the Teams window, and underneath it, it says raise. Or if you are on the Teams app on a phone, then you click on the three dots, the ellipse in the menu, and then the hand icon will appear and you can select it. It may be a little different depending what model and operating system your phone is. If you are joining through voice only on a phone, press *5 to raise and then again to lower your hand. Once you've been called upon, you will be able to unmute. To unmute on Teams on a computer or on the phone app, you click on the microphone icon. On the computer, it is in the upper right area of the Teams window. And on a phone, it is usually in the lower left of the Teams app. However, again, different models or operating systems may have the icon in a different location. If you are on a telephone and voice only, press *6 to unmute yourself once you are called upon. Thank you. And Adrian, I'll turn it over to you.
I appreciate you. Thank you, Dominic. And just as a friendly reminder, once your credentials have been enabled, there is a 3-minute limit. Up first to requesting to speak, my apologies in advance if I mispronounce your name. It's Hanifa Nayo Washington. Hanifa, your microphone has been enabled. Will you please unmute yourself?
Thank you. Can you hear me?
Yes.
Okay, wonderful. Good morning, everyone. Thank you so much. I really appreciate the work of the DOH and of this amazing advisory board. My name is Hanifa Naya Washington. I'm a new resident to New Mexico since August, and I am one of the co-directors of the Psychedelic Mental Health Access Alliance. And we have had the joy of working with Dr. Larry Lehman at the University of New Mexico toward the development and implementation of the GPAT study that is due to begin in 2020, in this first quarter of 2026. I had a recommendation in terms of a suggestion for subcommittees. I really appreciate the work that DESBA is doing in the equity, access, and cultural considerations. I really do want to lift up, and this is something that I believe Denali Wilson from HAF mentioned in one of the previous committees around a really need to look at affordability, reimbursement, and Medicaid pathways to cover this type of work and care. And so wanting to just lift that up for the advisory board to consider the developments of that subcommittee, specifically around, we're talking about equity. It's a pretty big word. It covers a lot of aspects. So I wonder if the subcommittee as it stands can really focus on what Deswa was focusing on and talking about earlier in terms of where are the intersections around equitable practices and processes within the subcommittees, looking at cultural considerations and access, but really, looking at who's going to pay for this, how's it going to be paid for, and really having a subcommittee that focuses on financing, reimbursement, and equitable access in terms of affordability. That's what I have for now. Thank you all so much.
Thank you. Next up to speak is Denali Wilson. Denali, your microphone credentials have been enabled. Will you please unmute yourself?
Good morning, everyone. I'm grateful to be here this morning and have the opportunity to address the board and the department. There are a lot of things covered, and so sorry if I jump around trying to keep to my 3 minutes. Grateful to Hanifa and the Psychedelic Mental Health Access Alliance for reviving this recommendation around third-party payers. Maybe the timing for that could be after we meet these first two draft deadlines in February and March. The board could consider the recommendations for additional subcommittees to support the work of the advisory board. On the timeline and the acceleration, I think it's going to be a real challenge. I want to support the board and the department in meeting what's been requested by the governor and the secretary. I think that the motto that will make it happen without creating anything that's difficult to operate under is really going to be lean regulations. If we're moving forward at a pace where we recognize that there's more to learn and operate an ability to iterate and adapt, I think early regulation should be as lean as possible. It's really challenging, and Colorado and Oregon are in a place where early, very dense regulations then become hard to correct when it's clear that it's not easy to operate under whatever the regulation that's been adopted is. In addition to echoing the board's commitment, or supporting the board's commitment to also prioritizing training and education, I wonder if it might be really valuable to consider, in addition to prioritizing what are the training and education requirements so that people can operate, finding a way to authorize a practicum site in New Mexico, because it's really
30
prohibitive for people who want to be trained to have to travel to Colorado and Oregon. And while I think reciprocity is a really important equity piece, we need to be making sure that we create opportunities for people based here who aren't currently licensed to access that training. And the travel involved could be cost prohibitive, in addition to the cost of tuition could be unnecessarily cost prohibitive. So I think the department would be in a place of authorizing a practicum site in New Mexico so that
You have reached 3 minutes.
So that trainings, thank you. That's all, and I'll add the rest to my to the chat.
Thank you. If anyone else would like to go ahead and speak, perfect. So I'm sorry, Desma, go ahead. Okay, next up is James Brown. James, your microphone credentials have been enabled. Will you please unmute yourself?
Morning, everyone. And again, thank you for letting me talk today. I just had a few comments. A couple things, for qualifications, I'm really looking forward to that meeting with Brenda. And again, thank you, Brenda, for chairing that. One of my thoughts and comments on that prior to this meeting, is access and qualifications for a variety of people. I would just like people to think about that, is who has already been trained in this wonderful thing, and those qualifications for those people is vast. New Mexico has a very rural community, and a lot of those people, I would say, don't hold professional licenses. And so think about who can qualify. And I would just like it to be opened, between therapists, massage therapists, anybody, pharmacists, nurses, doctors, of course. But, in the medical side with the ICD-10 coding, that makes sense to keep it as a medical professional in that realm. But once they code that, we're really transitioning that patient to a different service. And that service really needs to be thought about differently in a way than the medical model. And so with that service, we're going to be providing something different. And so those qualifications can also include other people. And so I want to make sure that, in Oregon, there's a variety of different backgrounds with these people, lawyers, again, just so many different people who don't have professional degrees, who barely have college. And I want to make sure that they're included. And so that's why I'm here today, is to make sure I advocate for those people coming up here, and that we include a large group of people who are trained appropriately, of course, but once they're trained appropriately, they will follow under the DOH and the licensing, and that'll go the way it always has and goes very well. And so, but let's look at those qualifications and say, let's include these other people. And so that's all I have to say today. Thank you so much.
Thank you, James. If anyone else would like to speak at this time, please go ahead and raise your hand on the Microsoft Teams application via your computer or on the phone. If you're joining us through voice, it's *5 to raise or lower your hand.
Hey, Disba, I know you had a comment earlier, but you were muted. Did you still want to speak?
Yeah, sure. Yeah, well, can we comment on the comments? No, I wanted to say from the equity access spectrum, the things that Hanifa was saying and Denali was saying, especially because I also was looking at the chat. When it comes to that practicum, that's a really good idea because, and I just wanted to point this out, we're seeing the kind of the practicum side of what that looks like. And again, also too, I think, was it James who just spoke a second ago, the chat, the facilitator is different in some ways than a medical professional, which is what Lita is also working towards with her program. It seems that, the medical professional, the Western medicine side, has a different perspective and intention when it comes to working with patients than would be different than, say, cultural considerations for curanderas and indigenous healers. So what does that look like when they intersect? That would be a great place for understanding what a facilitator, someone who is sitting with a person who is journeying, and that might be completely different than having the perspective from Western medicine versus someone who has been practicing this for decades and has the wisdom from, years. But on the equity side, what does it look like to travel? What does it look like someone from Mora or someone from Farmington or someone from Deming to travel to these different sites and the cost that might prohibit those things? But yeah, I just kind of wanted to make a little bit of a comment on that. Oh, the practicum. We're seeing that also with the early childhood education and the internships that are needed. And that's where I see kind of like the similarities in what I hear people are saying, is that it's one thing to have the knowledge and to do something. It's quite different than to actually be there sitting with someone and following them through what they need to have and the integration that's necessary. So I just kind of wanted to echo the possible concern that some people might have is, what does that look like in terms of training? What does that look like when it comes to, like Larry's committee, like end of care? Sitting with someone who is dying is a completely different thing than sitting, to some degree, than someone who might be having post-traumatic stress disorder from being a war veteran. And so I just kind of wanted to point that out.
Yeah, well, thank you so much. I really appreciate that insight. And I think I gave the equity committee so broad of jurisdiction because it's so important that this program doesn't become a big filter. And what I mean by that is when we're requiring more of people, we're requiring them to travel, we're requiring them to we're adding barriers to care, then we're no longer saying, oh, is this patient best for psilocybin? We're saying, does this patient have a good enough job and a flexible enough job where they can travel? Do they have the ability to travel, a mechanism, a mode of transportation? How far are they traveling? What's the cost of gas to get there? And things like that. So I definitely see your point that equity is so incredibly important because the last thing I want is this program to just turn into another instance of where, um, urban areas get preferential treatment. I think we have to very much consider how much it costs each person to make it to the administration session, how much it costs each person to take off that time from work. If we're able to get insurance coverage and that kind of thing, or education we need to provide. Like that's where I kind of stand on those issues, but I really appreciate them. Lawrence, you had a. You're muted.
Yeah, thank you. I had a couple of comments just on the training part. I'd encourage us to think about a team's approach here. I mean, that's a lot of how we're doing other forms of healthcare, and I mean, the idea that that there's somebody has a level of training that's sitting with people makes this really accessible, but that there's somebody else in the team that made that diagnosis is helpful as well. And one could actually have somebody who's a therapist that's not there on site that is available, because there are people that will come out of the psilocybin session. Most of the time people come out, well, occasionally people come out with more existential, even paranoid sort of issues. So think of it as like a team offering, and that is one thing. The other is to look a little bit about the indications and that we may need different training plans for different ones. Like in Colorado, they have, if there's certain diagnoses that, it kind of escalates to getting some consultation or someone else involved. And just to share one sort of quick example, PTSD can be very variable. If people have complex PTSD and they're having their first psilocybin session, that's a situation where honestly, many of the people I know who offer psychedelic therapy in other states are reticent there without having somebody who has experience in that level of trauma. So think about teams, think about different diagnoses and different teams for those is my thoughts.
Yeah, and thank you so much, Larry. And to add on top of that, one of the things I've considered for who our provider or facilitator should be, I've definitely considered having them be nurses. The reason why is that nurses are already trained to assess. They are trained to help with people, to have social communication. And so that assessment part, though, is really important to me because psilocybin can have impacts on your cardiovascular system. So if we can have someone there to just be able to say, even if it's not a psychiatric distortion caused by the psilocybin, maybe it's a cardiovascular incident, maybe it's a mental health incident or other things like that, where it may be beneficial to have a member of the healthcare team, maybe not a doctor, maybe not, you know, someone people trust less because there is a deep found trust doctors in our system, but that's neither here nor there. So I just wanted to talk about, kind of that point, and I will go ahead and turn over to Brenda.
I appreciate everybody's comment here because this is the warm up for the education and training. Absolutely. I'm really loving seeing everybody contribute to everything that's going on here right now, because it's going to actually speed up things for the meeting for education. But going back to what Despa was saying, the intersection, this is really important. People who are trained traditionally and people who are trained in Western modalities, what that's going to look like and how are we going to build together. And like Larry was saying, as a team, there may be a little bit of a hybrid here that we can start to work on together and work on something here with training and with a practicum or internship or however that's going to look like, and start to build on this as prior to the meeting. So I like this. Everybody's got their thinking caps on that are commenting on what training is going to be and what it's going to look like. So thank you, everybody, for contributing.
Yes, thank you. And I will turn back to Adrian for public comment.
Thank you. Next up is James Hosobo. James, I've enabled your microphone credentials. Can you please unmute yourself?
Yeah, can you hear me okay?
Yes.
Wonderful. Well, good morning, everybody. And this is an absolutely wonderful birthday present to be here with you all today. One point that I would really like to recommend to the board in regards to protect patient safety and maintain public trust is to implement a structured framework for monitoring facilitators that are providing the psychotherapy. I think this would literally include credentialing, background verification, and participating in a centralized facilitator registry. I think that this is really important to make sure that there are boundaries, non-violations, and any ethical conduct that needs to be surveillanced. I know that, human beings, we're all not perfect and nefarious behaviors may arise. And I believe that my recommendation for the facilitator registry might help mitigate and help bring harm reduction into this realm. So thank you very much for listening to what I have to say. And I look forward to the next meeting.
Thank you, James. Next up is Catherine. Catherine, I've enabled your microphone credentials. Will you go ahead and please unmute yourself?
Good morning, everybody. Thank you again for everybody's time and effort in these meetings. This is a very important thing we're doing here, and I just want to say thank you to everybody. Something I wanted to just weigh in on, Ian, based on what you were sharing. I've been doing this work for about 4 years now, and what I will tell you that has been extremely important and valuable is making sure that anybody that, like, I use an assessment, but anytime anything is flagged, like severe cardiovascular issues, epilepsy, unmanaged diabetes, I do require that they actually see a medical provider to get that further assessment. So I almost think it might be good to have 2 levels of assessment. There's the preliminary assessment, and then if a medical assessment is needed, I do think that that's something that we may want to very much consider. I liked your idea of including nurses, but I actually think there needs to be a step to make sure that the liability isn't and the onus isn't on the facilitators who don't have medical backgrounds. I actually use the www.psychedelicinteraction.com when anybody's taking medications, because it is a pharmacist website that provides contraindications. I prefer as much as possible to have backing from medical professionals that are telling clients what is contraindicated, what the issues are, not coming from a licensed therapist, at which, is something, but I don't have that background. And I don't want to see guides, facilitators, shamans, whatever, death doulas, be the ones that ultimately are responsible for medical care when we don't really have that background. So thank you very much for letting me speak. Have a wonderful day, everybody.
Yeah, and definitely I wouldn't want to exclude therapists or anything like that. My goal in having a nurse was having a nurse on facility. Um, it would just say if someone has like a serious incident, at least we have someone there to assess and who we can say we'll get them to the emergency room, but who can provide emergency care en route and who can, help out with emergency situations. Are cardiovascular incidents very common with psilocybin? No, but that doesn't mean we shouldn't still take steps to prevent an sentinel event. So just very important to me that we have someone, who is trained on medical properties and things like that, just to be able to say, is their pulse feeling thready? What did their lab results say? How are they, you know, cope, how is their body working, right? Because we don't want to add unnecessary stress into a situation, um, right? Like if we're treating someone for post-traumatic stress disorder, we don't want to give them new trauma by sending them to the hospital if they had, uncontrolled heart disease. Um, so it's more about an abundance of caution than saying each person must be allocated a nurse and be by them the entire time. Because in all fairness, Nurses are not psychiatric professionals. They are not psychologists. They are not therapists. So I do believe in the importance of integration and administration with a licensed therapist because that is their specialty. But at the same time, I recognize that we may need a nurse to say, hey, this person answered this questionnaire in this way. How are we interpreting those results? And things like that. Chris, you had a question?
Yeah, I just want to say, I think having a nurse on staff at these is going to be very cost prohibitive for everybody. And I think Colorado requires a BLS for their facilitators, which I think would be more than sufficient given the high safety profile of psilocybin. And in those rare conditions, I think the preliminary screening can mitigate other issues and requiring, clearance from a doctor to participate in some of this would be a much better option than having nurses at all of these sessions. That seems overly abundant. And I also think for integration and coaching and all that that should be broad as well. I think peer support workers and people of all walks of life can help people that are especially like them deal with these issues and how to integrate them. So just thoughts.
Absolutely. But I do still stand by the fact that the entire purpose of a nurse is to assess. We look at what is happening. We look at all of the details down to if there's clubbing in the fingers, if their skin is dry. We are looking at everything because we're trying to say, is this person medically stable? Are they going to be okay? Are they going to tolerate the medications they've been prescribed? And those kind of things are very important to nurses. So I've always, in my mind, when I envisioned it, not really, but in my mind, when I envisioned it, it was a team of therapists working in a facility. They would have their set of patients, and above them would be a nurse who would just be there to say, if something is going wrong, if someone starts to feel a certain way, nauseous, if they start to sweat, if they start to, experience signs that are sometimes normal symptoms, but can also be indications of other issues, we can look at that and have them properly assessed. It's just a safety thing for me. It's not saying that that therapists can't do the job. I believe therapists can facilitate much better than most nurses, but it is about just keeping sure that all of our patients remain safe. In terms of cost prohibitiveness, therapists are usually more expensive per hour than nurses, so it already would be like the therapist on its own is cost prohibitive. Adding one nurse to a facility staff is not going to, fully just derail that, but I am open to other opinions. Brenda?
Well, just having an overall safety plan. I think if you even have a nurse, like on the phone, say, hey, this patient is really having a hard time breathing. Something's going on because people, sometimes things happen and they've never had those symptoms before. So having a nurse just on the phone, you could be in a rural area and also know how far the hospital is or emergency. Having, all of that in place so that when there's an emergency that arises, you're on it, you're getting another opinion. And so have that all set up so prior to any sessions that are happening with psilocybin, it's all set. And so that just gives another layer of safety.
I would concur with Brenda on that. That sounds like a great idea. Even if the nurse was just on call, I hadn't considered it, but it is another way we could pass along symptoms and see if something is an emergency case and get them adequate care if needed. So I 100% support what Brenda was saying. Desba?
Just really quickly, if this is a discussion, because that does have an equity access, for role when we're talking about the telehealth, we were talking about telehealth, possibly for pre-session, then during the session, if there is a telehealth person available kind of on call, similar to if not everybody, you know, I think it was I have friends who are deaf, you know, they need a call, they have someone who's available to help them facilitate the phone call or anything else, but it doesn't mean that they have to always be, you know, on site. But especially for those rural areas, that's where the intersection of equity access could also, you know, play a part with our regulations.
And Alana?
Yeah, hi. I'm just a little, can I get a little bit of a understanding of like kind of procedurally, because we're in public comment now. So are we having discussions or making decisions? Because I was kind of
No, we're
holding
just
for other times
responding.
to have that kind of
No, we
conversation and
were
discussion.
responding
Is
to
that, I mean, just I in these advisory boards, we almost never respond to public comment. We receive public comment, then we have other times when we you know, discuss as a board. So I just kind of wanted to
so nothing
like
in
how we
the
set that
public
up.
comment period is going to be like an official rulemaking procedure. We are just trying to hear from the people of New Mexico. We're trying to let them hear what we are thinking on this issue. That way, when they come to committee and we are ready to work, they can say, okay, well, they've already heard this idea or that idea or some other things and maybe can begin to bridge. But it then right now is not an official rulemaking capacity. We kind of had a little bit of extra time in between people who were raising their hands. So we just had a little bit of discussion. Nothing set in stone right now.
Okay, I mean, I would just posit that if we get a list of people, if we're like and done, there's nobody else, but usually we have like kind of the way I've been in these before is a list that we know ahead of time, these people are giving public comment. We wouldn't open it up for like any kind of free discussion unless we were at the end of it. I just want to make sure everyone has a chance to make their public comments.
So I had not been given a list of the who had requested to speak for public comment. I had just been going off of who was raising their hands. So whenever there was no one left raising their hands, that's kind of what I went to. I see James Brown is left, and since we have about 8 minutes, he is free to speak.
James, your microphone has been enabled. Will you please unmute yourself?
Again, thank you, everyone. This is great discussions. One of the things I had on public comment today was with the thought behind a medical professional, really with that RN thought, it's more of a medical professional thought. I really like the Colorado idea of, stepping it up a little bit. Oregon didn't have the requirements on a facilitator to have BLS, that basic life safety. I think that's important too. That brings that RN discussion in, or medical provider, again, somebody that's just medically trained, and basic stuff in this stuff. And when our experiences, when we're in our sessions with our clients, that pre-screening is very important. Preparation is huge in this. And so as you prepare and you see those things and you see those challenges that might come up during their session, you have to make arrangements. And I like that maybe you have that hotline or on call ability of an RN or medical professional being that person who can make that call. And then it's up to the facilitator trained with the individual. Again, I want to focus this back. We keep focusing not on individual patients. The patient's experience is very important here and what they grow and experience and overcome. And so with that safety plan, it's huge. And so that'll come into fact here is like, what have other states done with their safety plans? Let's look at that. And then that individual personal, once we ICD-9 code them, then they get turned over to the psilocybin program. And then once that individual is turned over, again, we got to take care of them through safety. And that individual plan of safety is very important here. And that includes the pre-screening. And whether you're doing medication pre-screening or polypharmacy or polysubstance or whatever else you're looking at, their health conditions, it's important to have those people and resources available for those patients to make the call individually. So again, this isn't a one and all, one and done. We need to look at individuals here and think about that too when we make these decisions. This is going to be individually based on their growth so that they can overcome these things. Thank you so much.
Thank you, James. Next up is Gregory Evans. Gregory, I've enabled your microphone credentials. Will you please unmute yourself?
I'm here. I'm going to keep it to 90 seconds. I have a comment kind of directed at the community that is supporting the community participation here today and moving forward and what we can do to be as supportive to the board, because I believe that all of us are here to support the advisory board in their capacity to put these recommendations together and then move them up. This is a political process. I just want to remind everybody that we need to know which room we are in and what that room needs at that time. There's a lot of really valuable discussion here on very specific topics that I would encourage you to write those thoughts down, show up to the appropriate meeting, and make sure that those thoughts are put into the correct place where they can be more effective rather than public comment in this space. I think that we have a process to collect some of those thoughts, but we don't want to lose these thoughts, and this is not the space to collect them. Outside of that, just great job, Ian. Keep doing you. Thank you.
Thank you so much.
Thank you. At this time, no one else has their hand raised for any additional comment.
All right, seeing as there is no additional comment, we reviewed the summaries from the committees, an update from the program, and just generally discussed and heard public comment. Other than that, I say we move to adjourn.
This is Dan. I'll make that motion.
A second?
Second it?
All right, are there any objections to the motion to adjourn? Without objection, the motion passes and the meeting is adjourned. I thank you guys all so much for coming and have a wonderful rest of your January.
Thank you, everyone.